When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
Oh, Hilton stay, your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay, a holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
Dr. Raj.
Dr. Raj Dasgupta.
The most interesting pulmonologist in the world.
Welcome to the Dr. Raj Podcast, a show all about empowering knowledge, addressing difficult topics, raising awareness, and being positive. Dr. Raj is a quadruple board-certified physician, associate professor of clinical medicine, and the associate program director of internal medicine residency. He was a co-host on the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj Podcast. And what is this a podcast of? A podcast of happiness and wellness and great people, amazing stories. And my personal favorite thing to chat about is always disease awareness. And this podcast will actually be released in April of 2025, which is Sarcoidosis Awareness Month. And sarcoid, as many of you know, is a disease that's near and dear to my heart. So today, I have a special guest. I have a sarcoid specialist who just so happens to be a good friend of mine. And with that being said, I'm going to introduce Dr. Bobak Akavan. But before he says anything, I got to read his bio. That's the rules here. So, Dr. Akavan is a native of Los Angeles, has traveled to Granada and New York and Texas to complete his medical training. He completed a chief residency year in internal medicine at the University of Texas at Houston, and was a chief fellow at Cedars-Sinai Medical Center, where he currently practices as a pulmonary and critical care physician. Dr. Akavan spends half of his time in the ICU and the other half doing pulm consults and doing some clinic. Dr. Akavan has a special interest in sarcoidosis and is the medical director of the Pulmonary Sarcoidosis Program. Since joining Cedars-Sinai, he has helped build a strong, structured, multi-disciplinary sarcoidosis program. And I want to say one more thing before I introduce him, is that his comments are his own and do not represent Cedars-Sinai. And he is not endorsing Cedars-Sinai on his behalf. And with that being said, Bobak, how are you doing, bud?
Good, Raj. Thanks for having me.
Oh, of course. Why wouldn't I? So I want this podcast to be for the most important people, which are the patients, people who have sarcoid. But there's always a couple who don't know much about it. So my first question to you is my standard go-to, which is, how do you explain to the first-year medical student what is sarcoid?
That's a good question. I sort of have like a spiel, I think, that I say the same thing kind of to everybody.
Okay.
So sort of the way that I think about it is that there's some sort of like typically environmental trigger or stimulus or antigen or something in the environment. There's a lot about that, maybe some inorganic metals or whatever it is. And that sort of stimulates our immune system. Probably in theory, we inhale it or we're somehow exposed from the lungs, and it kind of stimulates our immune system to react and form these granulomas and cause this inflammation towards whatever it is. And for most people, probably they don't even know about it, or it happens and then it goes away or whatever. But then in some people, it just kind of goes unchecked, and their immune system just keeps on going and building granulomas and causing this disease.
Man, so with that being said, I wanted to compile some of the classic questions that patients have when they first get that diagnosis with sarcoid. So I got my list. I'm going to start off with what I feel is one of the most common, which is, hey, what organs can be infected by my sarcoidosis? And which of those organs will probably be the ones that you and I should worry about the most?
Yeah, that's a good question. And I feel like I get that question more from the clinicians that I work with as opposed to the patients, honestly.
Okay.
But it is something that we talk about in every visit. So I always tell people that, the same story, right? That there's this antigen that we inhale. And so because we maybe inhale it or we're exposed to it from our lungs, that really the lungs is sort of the primary organ here. So I don't know, we say different numbers. I usually say something around 95% of people have lung involvement. But when we say that, really there's just like kind of something intrathoracic. So there's lymph nodes that are usually involved in almost everyone, really. I mean, like if I have someone who has no lymph nodes involved in the chest, I almost even wonder about the diagnosis. But typically, I feel like that's the main thing. And then there's a subset of those people that have actual lung involvement themselves as opposed to the lymph nodes. So that's the main major organ, and that's really the disease, and that's why the pulmonologists are usually the ones that are really kind of the quarterback of this disease. And then actually, I just had this conversation 30 minutes ago with a patient, but the next kind of top three organs that I bring in are the skin, the other lymph nodes outside the chest, and the eyes. So those are the big ones. I think, and then next, and that's something in the realm of like 15 to 20% of patients probably have that. So that's lungs, skin, lymph nodes, eyes, and then the other two organs that we really kind of worry about are the brain and the heart. And again, it depends on where you look, but probably somewhere in the 5% or maybe even a little higher for CNS. And, that's probably also quoted in the heart if you look, some 5%, but I think we know now that it's probably much, much higher than that, especially when we look at kind of autopsy data and other stuff, or how hard you're looking for sarcoid in the heart. You probably find it in maybe even close to the other numbers I mentioned for the other organs in the heart.
Yeah. So this is a great question. So a patient wants to know that I'm sent to a doctor because someone is worried that I may have sarcoid, but how do you confirm? What information do you use to actually make that diagnosis?
So I love to have tissue with a granuloma. I think the that's the way that we have our diagnostic criteria of how to diagnose it, and that's what makes me feel the most confident. And then I think it depends on the organ. So like for me, best case scenario, I have someone who has classic story. They were doing some construction, or they had some mold around their house or something, and sometimes people tell me they just moved into a new house or something, some kind of story that fits nicely. And then they come with a CT scan that shows these classic sort of micronodules around the airways and the lymphatics. And they have lymph nodes that are enlarged, just kind of a classic kind of upper lobes, the way that we want to see it. And then we have a bronchoscopy. We do some biopsies. Biopsy shows non-caseating granulomas, no other diseases like cancer or other kind of things on pathology. We have cultures that show that this is not an infection because, as you know, Raj, this exact thing that I described to you could be exactly an infection and look exactly the same. So, I like to see that there's no infection there. And I think, to answer your question, the best case scenario, we have all of that, and I feel very confident, and that's the diagnosis of sarcoid. Doesn't always work out that way, but
But I'm going to put you on the spot. I'm going to throw you a curveball. So, are there patients you manage where you don't get a biopsy? You know what I mean?
yeah, I knew you were going to ask that. It's a good question. I want to ask you that, actually. I mean, I think people give you different answers. I'll tell you that, like, I have patients that we haven't biopsied, and it's really dependent. I think so. On one hand, I have patients sent to me that have like carried a diagnosis for years, and I have all their scans, but they have no biopsies. And I think with time, I can look back and be like, yeah, I mean, that looks like sarcoid, and nothing else has happened. So there's that. And then there's like the new patient, maybe like the young healthy guy in their 30s or 40s, mediastinal lymph nodes, maybe classic appearing other stuff. And then the question is, do we biopsy it? And as you know, we don't treat everyone with sarcoid. So I think we have some data with some studies that, well, maybe if you have no symptoms, if you just have symmetrical lymph nodes in your chest, you have no fevers, night sweats, other stuff. You have no abnormalities in your labs. Your cell counts are normal. Nothing else is kind of looking like a lymphoma or a cancer. You could potentially just observe that over time and do some serial imaging. I honestly, personally prefer and tend to favor the biopsy just because I think it's nice to be sure, but especially in a new patient that I just saw for the first time. But sometimes I'll see someone, 6 months later and they have a serial scan already. And I'm like, well, it's been 6 months and nothing's changed. So I might feel more comfortable in that state. So I think, long story short, it's incredibly variable. And I like to involve the patients a lot. I like to be like, look, if you feel, I can't say like 100% certainty. Maybe there's a very small chance of this being like lymphoma or something else. And if that's a risk where it's not acceptable to us, I say us because it's like we work together, and maybe we want to do the biopsy, or maybe not. And the other thing I'll say, Raj, is I think it depends on what we're talking about. Like, some patients I see and we're talking about like a surgical biopsy or something like, really big. And that's, let's take a few steps back there. I mean, for us for us, what we like to do nowadays is EBUS, and we do a bronchoscopy, and this can be done in 30, 40 minutes, very low risk. So I think that's kind of a safe procedure to do when we're in this situation.
I'm just going to keep on going with this because the next question makes perfect sense. So you make the right diagnosis, and one thing what patients frequently ask is my sarcoid quiet? They don't really use the word remission, or is it active or flaring? So how do you determine if one of your patients with sarcoid is kind of having a flare versus more of that quiescent, quiet disease, minding its own business?
Yeah, so I guess maybe we'll focusing a little bit on the lungs if they have lung disease.
Okay, let's do that. Let's do that.
I think it's hard. I mean, sometimes patients know, they're like, look, I have all these like symptoms. I'm coughing more. My breathing's worse. I'm tired. I'm achy. I hear that a lot. I'm fatigued, and that sounds flary. I do like to kind of have something objective that says like, yeah, there's evidence of active disease. So I think that's also a question I always like to know in the beginning, right? Is this active or not? Because someone can have a really, really bad looking CAT scan, but have no symptoms and nothing active. It's not getting worse, and that's fine.
So are you basing it being active only on imaging?
So yeah, I think the three things, I mean, the symptoms is one. The second thing I really like is the imaging. For example, is there imaging in two parts in time where, let's say they have these consolidations or whatever, and then on a few months scan or whatever, now they're worse, they're bigger, they're, there's more consolidations or something like that. That to me tells me that this is active, it's getting worse. The other thing that I like is pulmonary function tests. And this is kind of a debated thing in sarcoid in different ways, but I really do find that, like, if we look at their numbers and they all look, say, 10% declined compared to prior in conjunction with their symptoms and CT scans, that to me tells me, that things are active.
So are you kind of one of those, when they come see you and follow up, they're getting some spirometry, what you call the pulmonary function test, standard routine regardless, or are you kind of cherry picking who gets one?
I'm pretty free with the spirometry. I think I like to get them. I mean, for me, it's really easy. Usually they'll come they'll get it and then they'll see me right after. So I think I usually almost time the visits around when they might need that, if it's a month or 6 months. But yeah, so I usually, that's like a test. To me, it's like a cheap, easy test. There's no radiation. It's not harmful. Like, we're not talking about CT scans every visit. It's like why not have this data a little bit? It's like how we're monitoring. And then, just to throw this in there, I don't know if you're going to ask me this, but I do in some cases, although I would say this is rare, get a PET scan. I don't do that routinely, but some people come with a PET scan before because they're like, oh, with this idea that this is cancer. And if there's like, active metabolic activity everywhere, that says that it's active. That still isn't always a reason to treat it. But if we have like, 2 over time, or for example, if someone is scarring everywhere in their lungs, but then they have new symptoms, we get a PET scan and everything's super active. That's a complicated situation, but that's something that I think about sometimes, but it's not something I do routinely.
So how would a patient interpret the word PET scan? For me, I'm just nodding my head because I'm like, yeah, you're speaking my language, but can you dumb that down? What is a PET scan?
Yeah. So basically, it's difficult. They have to go on a little bit of a diet, make sure they're not, taking glucose and stuff, because cells that are active are eating up glucose and things like that. And so we inject them with a dye that will basically go to the cells and show activity. So, that can be active it's very sensitive. I mean, if you've got a cold and you checked it, things might be active. But if you have cancer and you checked it, things might be active. So it's kind of like, it's hard to make of it. But, sometimes if you have scarring everywhere in your lungs and it's kind of hard to know, like, is this just scarring? Is there active inflammation? And the PET scan shows well, yeah, all of the lungs and the lymph nodes are very inflamed. That's kind of suggestive.
Yeah. So let's talk about practical symptoms for your patients, and you can answer it as we're assuming it's going to be lung sarcoid, but one of my patients wants to know, like, on a day-to-day basis, like, what are some of the warning signs that say, hey, my sarcoid's flaring up, or I need to kind of go to the emergency department? Do you have any tips to tell your own patients?
Yeah, I'm not specifically for emergency department. I feel like at least in most of my patients with sarcoid, we can sort of kind of figure stuff out without having to go to the ER in many cases. But there are times where, maybe this is derailing from your question, but like we always kind of keep infection in the back of our head, especially for our patients on treatment. So, if someone's on treatment and like they start to have new fevers, cough, and phlegm or something like that, we always kind of wonder, is this infection versus the sarcoid? Especially to me, the worrisome symptom is shortness of breath. When patients tell me they're really short of breath or their oxygen levels are lower, that always sends off a little bit of an alert for me. And I like to investigate that a little more aggressively than I would for someone who just has a cough. And then, obviously, if someone has cardiac sarcoid or neurosarcoid, or they don't, but they have symptoms such as really bad palpitations, skipping, like they're going to pass out or they did pass out. Those are really sort of concerning things that need evaluated from a heart perspective. Obviously, if they have like a seizure or like a weakness in one specific area or vision issue or speech, those are concerning for a stroke or even involvement in their brain. So that's something that I think obviously needs more urgent attention.
Yeah, and so now that it's something that needs to be treated, the patient's probably going to ask you, hey, Dr. Akavan, what are you going to treat me with? So what is our main therapies for sarcoid patients, especially if they're symptomatic?
Yeah, and I'm sure this is ever the internet everywhere Googling it, but obviously prednisone is the main thing that we use.
So steroids.
Steroids.
Okay.
Yes. I don't like steroids. I think we've learned that they have a lot of problems. They have side effects, especially prolonged steroids. But look, in the beginning, if someone's really sick or like for example, we had someone recently with pulmonary sarcoid and a seizure, and they had neurosarcoid. Like, we want to give something fast that works fast, that's strong, and will combat this inflammation up front. So really, that's steroids. I mean, I think they're strong, they work well, they work fast, and that's really why we use them up front. That being said, I really do like most cases to just start something else, right away. I mean, we've had this sort of like idea in sarcoid that like, we got to be on prednisone. That's the treatment. We'll be on it for 6 to 9 months and we'll kind of maybe see if we can come off then. But I still see people have a lot of issues with steroids. And, I don't know that there's a good reason why we can't just start something else a little sooner.
Yeah, well, you actually like stole my follow-up question a little bit, which is there other things besides steroids? And before you answer that question, just tell my listeners, like, what are those side effects of steroids you're kind of worried about and you're implying?
Yeah, I mean, some people just taking them even after some days, I mean, they can't sleep, they're agitated or emotional. I mean, these are like steroids, like road rage, so roid rage. So it's like, people really feel that. But that's initially, and then as we go on for months, weight gain is a huge one. Diabetes gets out of control, their blood pressure, eventually like cataracts, vision issues. If you have wounds or if you need to be have surgery or something, healing. I mean, and then infection is another risk. I mean, there's so many. So I think I don't like long-term steroids. Sometimes we have to be on them, as we're working.
Yeah. So this is back to that segue. So if someone's getting a little more symptomatic on steroids, or you're just kind of stuck on them for whatever reason, what are some other common options that you could offer to your patients who have sarcoid?
Yeah, I would say, this is also my personal disclaimer. This I always tell my patients is that like we don't really know like that one thing is better than the other or what's great. I mean, it's a rare disease where it's different in different people. We're still learning about it. Thankfully, though, Raj, there's a lot of trials that are ongoing and looking at different medications and comparing some stuff and seeing what might work. So that's really cool, and that's something that I hope we have more information of. But what we do know, based on maybe less quality scientific studies, is there are some medications that work, and probably most commonly used if you survey pulmonologists and just look is methotrexate. So methotrexate is commonly used. That's like often a pill that you take weekly. Personally, I actually don't reach for that one at first. I think we've had this chat at some point in the past, but I like CellCept. Also, not strong data to support it, so I can't come to you and Raj and say, look,
Yeah.
like this is a better medication. It's got data. It's going to work better. I can't say that, but I do have a lot of patients on it, and I think they tolerate it a little better, and they seem to do well. And so I like CellCept. Use that sometimes. Methotrexate still sometimes. There's other ones like azathioprine, which kind of don't use as much maybe, and like leflunomide also don't use as much maybe. And I will say usually when I'm getting into this realm of like, second, third line, I do like to include our multidisciplinary team and our rheumatologists. And like, that's where we really kind of need to put our heads together and get some help.
Does it ever feel like you're a marketing professional just
speaking into the void?
But with LinkedIn ads, you can know you're reaching the right decision makers, a network of 130 million of them, in fact. You can even target buyers by job title, industry, company, seniority, skills, and did I say job title? See how you can avoid the void and reach the right buyers with LinkedIn ads. Spend $250 on your first campaign and get a free $250 credit for the next one. Get started at linkedin.com/campaign. Terms and conditions apply.
In Walmart's Newville, time was ticking away. Only a few nights left till the big holiday. But last-minute gifters had no need to worry. Walmart Express Delivery got their gifts in a hurry. From Nintendo to Nespresso and Lego flowers, they could check off their lists in as fast as an hour. All of Newville, East, West, South, and North, could order gifts up until 5 p.m. on December 24th. So this holiday, just do as the Who's do. With gift delivery this fast, they all gasped. From Walmart? Who knew? Subject to availability, terms and fees apply.
And when patients hear the name methotrexate and azathioprine, who's our best friend and our enemy? It's ChatGPT. And are a lot of your patients get kind of worried? They associate methotrexate with cancer therapy and other things and side effects. How do you cross that bridge? Is it a matter of that patient trust, or how do you approach that?
Yeah, it seems weird, right? It's like they have toxic side effects and all these other things. So I think it's important to know that dosages can be a little different, and we're monitoring these things. At both medications, when we start them, we look at the liver, the cell counts within the first month, usually make sure everything looks okay. I also like to sort of titrate up the medication slowly, make sure they tolerate them okay, side effects, fatigue, GI, stuff like that. But it's different than when they're used in like chemotherapies and other settings and stuff like that. So I think it does. It's like I share that with them. I mean, it's not like I don't tell them, don't worry, it's nothing. But I do feel that it's definitely safer to be on these than prednisone long term, and I do feel that they help, and we can monitor them and whatnot.
So now a patient's on these medications, and they ask you the question, "Hey, am I responding? I don't feel like I'm responding." But sometimes it could be a symptom gets better, sometimes it's not. How do you come up with that plan to say that this is the right treatment, and they are getting better?
Yeah, I mean, what I love to hear is I usually will do something if I start treatment, maybe something like a 4-week or 6-week follow-up, so kind of closely. And I like to hear that they're feeling better. So, like some patients tell me that I couldn't even walk to the bathroom. Now I'm walking, no problems. I love that. I love to hear that patients are feeling better. So that's really important. But like you said, maybe not everyone's feeling better, but we're looking for other things or whatnot. So I do follow up usually with the pulmonary function test.
Okay.
I really like to have something objective before starting therapy and then after, so that I can really say, like, look, your lung function was at 50% capacity or something. We started treatment and now it's at 70% capacity. That's like a nice objective improvement. I don't often get a CT scan right away because I think this is enough for me usually, but sometimes, or maybe down the road, it's nice to show that the CT scan is looking better.
Yeah. Well, let me throw you the curveball. What about blood work? People love blood work. Is there anything you like to order to monitor? Like, I know there's inflammatory markers out there. Are you a fan, not a fan? What do your partners do?
Yeah, our partners and we do check them. It's funny, I didn't even think about it because I don't put a lot of utility in it, to be honest. I mean, I think like if you're feeling better, your lung function looks better, especially if your CT looks better, I'm not going to care that much that your inflammatory marker is a little here or there. But yes, we typically do get, inflammatory markers. Those are things like sedimentation rate or CRP. And we do tend to check ACE levels, which is a biomarker that's been studied in sarcoid, although we've learned over the years it's like probably not that good. And then we use something sometimes called soluble IL-2 receptor, which is like a nuanced thing that probably most people don't check, but it's something that's probably a little better than ACE. And we like to do them, especially because here where I work, we're starting a registry and we're trying to learn more about patients and what happens. So
Nice.
if we have a registry where we have these data and we can say, look, the patients with this number showed that they did better down the road or something, then maybe can help us learn how to help patients more.
So let me ask you this. So, of course, a question that many patients ask me is, well, what's my outlook? What's my outcome? You know what I mean? So let's talk about the patient that gets a diagnosis of sarcoid that's asymptomatic. What are the chances of them flaring or just staying quiescent the rest of their life? Or what about the patient that comes in, has maybe just the pulmonary stuff? I hate saying just because it's a pain in the butt, but you treat them and they're getting better. What are the chances of that patient going into remission? So how do you address both when they ask you?
Yeah, and this does come up a lot. And I think, when someone is, for example, let's take the classic asymptomatic, just
Okay, let's do that first.
Yeah, that's easy. I generally feel quite confident for those patients. I've learned over the years, I sort of never tell someone like, oh, 100%, no problems, everything's great. I won't say that. But if someone is otherwise young and healthy, they just have that, they have no symptoms, it's really like we're talking about like a, I don't know, 70 to 80% chance that there's going to be no problems, especially if some time has passed. Then there's the person who has maybe a little bit of a cough and like a little bit of stuff in their lungs, but it's not progressed and it's not like they don't have a really bad shortness of breath, really bad pulmonary function tests and stuff like that. Those people still probably do well. I would say more than half of them do well. So I generally still, I have a lot of patients, that scenario I just told you, and they're like surfing and like playing sports and they're active and they do just fine over maybe, we tend to think or wonder if the life of a granuloma is like somewhere in the 1 to 2, 3 year range, and maybe over that time just goes away. And I think I like to tell people that if they've been off therapy and stayed off therapy for a couple years, it's very unlikely that it's going to come back. Many people can stay without it and that's it. But we always kind of want to monitor and just make sure we're paying attention just to catch it if it does. But yeah, and then last thing I'll say is that I do have patients who had sarcoid or maybe fibrotic sarcoid like 30 years ago, and now they're coming back and they have a couple symptoms and we're trying to tease it out and see what it is. And that does happen sometimes.
Yeah. So, I mean, we're getting close to the end, but I'm going to throw one more curveball your way. I think nowadays the sarcoid community is, aware that if you have sarcoid in one place in your body, it's probably somewhere else. And the hot topic is always the heart. You know what I mean? And I just want to know, in your practice, have you been discovering and diagnosing cardiac sarcoid more? It seemed like it wasn't as popular, and maybe because we were doing a good job looking, a decade ago. But now it seems like you can't escape someone talking about getting an MRI or a PET CT or both or a combination. Yeah. So how is cardiac sarcoid in your practice?
Yeah. It's funny. I see a lot of new patients and they come to me for their lungs, and like we talked about, maybe their lungs aren't that bad, but then they're telling me these things like, oh yeah, well, sometimes I feel like I'm going to pass out and my heart's skipping beats and things like that. And I kind of say, oh, okay. Or their chest hurts and, I have a lot of like numbness and tingling in these areas. That's all new. And then, these things sort of as a sarcoid doctor make me think about sarcoid everywhere. So sometimes I feel badly. I don't want to overwhelm and just kind of let's MRI your everything. But I think, I think I take it stepwise. I think everyone, based on our society recommendations, deserves an EKG. And if the EKG shows some conduction abnormalities, let's take that one step further and do some more advanced imaging. For the people that have a normal EKG and no symptoms, I think probably we feel pretty good that we don't need to do too much,
So you're not an echo up front. You're not an echo up front. That's always kind of the spicy question.
Yeah. I think that, actually, I think the most recent ATS recommendations don't necessarily say echo for screening, but what they don't talk about, and what I do is when you do have bad lung disease, I do screen with echoes periodically because I really want to look for pulmonary hypertension, which is something that I don't know if you're going to ask me about because that's a whole nother topic. But we don't like that in sarcoid. So for people who have lung disease, I do get echoes for that reason. And sometimes we find stuff, or somebody who's got shortness of breath, other stuff. Yeah, that's different. But just for someone who has no symptoms, normal EKG, I tend to leave it alone and just go with that.
And I like what you said. It is overwhelming. You just told them to have sarcoid, and now all of a sudden we're doing a big MRI. Where I agree with you. We're definitely on the same page with that. Yeah. But I do want to ask a couple of questions just in general, our sarcoid patients about lifestyle. So, I mean, medication's one thing, and I'm not very heavy-handed with medications, but I do believe something that everyone could do is improve their lifestyle. What are some recommendations that you like to make to your patients to help them live better, live longer with
Yeah,
sarcoma?
yeah. You know what? I'm already going to tell you that I'm going to turn this question back around on you in a second because I want to know what you think because I don't have a great answer for this. And I just got asked this, and I wish I had more stuff to suggest them. Obviously, I tell people, eat healthy, exercise, stay active, especially when you have lung disease. I mean, I think as long as you're aware of what you're doing, I usually recommend pulmonary rehab if people have lung involvement so that people are active, monitoring their oxygen, but, really using their lungs and whatnot and staying fit and healthy. Probably the one thing I do kind of bring up sometimes is like vitamin D and calcium supplementation, which does this is a debatable topic, but this does make me a little nervous in sarcoid because, so sometimes as you know, the vitamin D gets converted to calcium when granulomas are active, and that calcium sometimes is high in the blood, but sometimes it just gets peed out into your kidney and you get calcium in your kidney, and that can be its own issue. And I worry if we were really giving a lot of vitamin D to someone with active sarcoid, we might be sort of like fueling this process. So that's something I just kind of caution. I mean, I think I had a patient who asked me like, well, should I avoid dietary things? And I don't think so. I mean, I think it's okay to just, be mindful, but I just wouldn't do extra supplements for those specific things. But other than that, I don't have anything really particular that's outside of like the normal stuff that we do for lung health and things that we do or don't know. Some people ask me about anti-inflammatory diet. I don't know if you were going to ask me about this, but I would say like, yeah, I mean, I think, yeah, maybe. I mean, I think it's like if somebody's willing to try that and then give it a see, and if they feel better, like, who am I? Yeah, totally. I mean, if it works for you, it works for you. Some people may have more stress doing that, and that may not be worth it. But what do you think about that, Raj?
So, for my patients, I always believe in like the pillars of health. And I think it's all about health span and not lifespan, meaning that you can live forever, but you'll get Alzheimer's and heart disease, and my prostate will be yay big. You know what I mean? And I think a big part of that is sleep. I do sleep medicine. So I really feel that, some of my patients, because of those steroids, are looking a little cushinioid. They're snoring at night. Yeah. They have insomnia. You know what I mean? They could be iron deficient with restless legs, or they're just not making sleep a priority. So I think that's one thing that I just kind of add my training to. But I'm really a big advocate about patients with sarcoid have a high incidence of depression and anxiety. Yeah. And whether it's just the way I talk to them or, sending them in the right direction or just addressing some of the elephants in the room that, they can't do what they want anymore and they are getting depressed, I think it just means a lot. And that will always lead to the other things like, just moving. I think like making patients jump on that treadmill. And that's not nice when you have osteoarthritis, you know what I mean? Yeah. But I always try to be very, encouraging and take extra steps. And I think me and you are on the same page, which I don't promote any supplement beyond just eating the recommended diet allowances. Yeah, I think that's what you need to do. And many things that we talk about, you could supplement by eating the right foods. So we're on the same page.
Yeah, yeah, totally. And I like what you said. I definitely feel that patients with sarcoid, it's a difficult, complex thing, and it's for the patient and the physician. I mean, it's tough. So I really try to spend a little bit extra just to really kind of make sure we're hitting everything and talking about everything that needs to be talked about. And sometimes, like you said, it's these difficult things too.
So I got one last question for you. All right. So it is Sarcoidosis Awareness Month, and I want to know, what do you want to let your patients or tell any patient with sarcoid, once they learn they have it, they carry the diagnosis, is there anything encouraging you want to tell them?
I thought you were going to ask me about in general. I think I want to say is that, I think we need to be more aware about it because people go months and they don't know the diagnosis, or sometimes it's tough. I mean, not to point any fingers, but someone like you or me, maybe we will notice this and say, oh, this looks like sarcoid. I mean, this is what we know, whatever. But I think just being aware about it and having ideas so that it pops into patients' and clinicians' head earlier on, But to answer your question,
yes,
encouraging things. I think that, I guess from the lung standpoint, I mean, I have a lot of patients with interstitial lung disease that's not sarcoid. And I think sarcoid is an interesting thing. I mean, it's one of those diseases where a lot of people just remit. A lot of people go away. A lot of people, well, maybe we need to be on treatment and then we can come off and stay off. But even then, we really should be trying to come off again. And say you don't come off initially, a year goes by, 2 years go by. Well, we should try again. It's like, it's not like other types of disease where, yeah, you're definitely on life therapy or something for years and we don't know. Yeah, maybe even after the second time, we really should still be trying to taper patients and, see how they do as long as we're doing it carefully. So I think that's the encouraging thing I would say. I have a lot of patients that tell me, oh, yay, it's not cancer and I'm so happy. And I think that's a great thing, but sometimes it can be a hard disease, sometimes it's not always so easy. So I think, I'm encouraged that we do have centers like where I work now, for example, that are really big multidisciplinary. So, I encourage patients to really get seen at advanced centers where, we can all put our heads together, try to come up with a patient-centered treatment plan, really look at everything wholeheartedly. And I think that's something that's been going on more for sarcoid. And I think that's my encouraging take-home point is that, we're really trying here to make a difference to help patients.
I love that, man. And Bobak, thank you for coming on the podcast today and just giving us your opinion. It means a lot to my listeners, to my patients with sarcoid. Thanks, bud.
Yeah, this was so cool. Actually, this is the first time I've done a podcast, so I'm excited.
All right. Well, let me just say this for closing is that everyone who's listening today, Bobak is actually a good friend of mine. And one thing I've known that as I get older, it's hard to find time to meet new people and to form new friendships. But this dude is the real deal. I just think he has such a great heart. If I could say anything about you, Bobak, why I kept in contact with you, because you're so good on the inside. I'm sure you're smart. You are smart. But I love the way you just approach people, your demeanor, and your patients and your parents are both very lucky.
I appreciate that, Raj. Honestly, it's great chatting with you, being your friend, and being on this with you, and I appreciate it.
And thank you, everyone, for listening today on the Dr. Raj podcast, and we'll be back again in a few weeks.
Thank you for listening to another episode of the Dr. Raj podcast. If you enjoy the show, then please make sure to follow us on your favorite podcast app and leave a rating while you're there. This show is for educational and entertainment purposes only and is not intended as medical advice. This has been a production of MedPrep to Go, and you can learn more at medprep2go.com.
Hey, Ryan Reynolds here for Mint Mobile. One of the perks about having 4 kids that you know about is actually getting a direct line to the big man up north. Mm-hmm. And this year, he wants you to know the best gift that you can give someone is the gift of Mint Mobile's unlimited wireless for $15 a month. Now, you don't even need to wrap it. Give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan equivalent to $15 per month required. New customer offer for first 3 months only. Speed slow after 35 gigabytes if network's busy. Taxes and fees extra. See mintmobile.com.